Hello, my name is Nigat Saeed. I'm a family nurse practitioner student at Franklin University working with my clinical preceptor and reporting about a possible transfer for a patient, Mr. JB, who happens to be a male African American, 59 years of age. He came to the clinic around 10:30 a.m. Complaining of mid-sternal chest pain. The pain was sudden in onset while he was taking a routine walk in the morning. The pain scale is from 1 to 10, between 6 and 7. Pain radiated to his left shoulder and jaw and the neck, and pain was accompanied with nausea, diaphoresis, and there was no history of previous coronary artery disease, peripheral vascular disease, or stroke. Patient has experienced this pain for the first time. Patient has a previous medical history of high blood pressure for the last 18 years, diabetes for the last 10 years, high cholesterol for last 6 years, and the patient is obese with 235 weight of 235 pounds. He smokes, he's a chronic smoker, smokes about 10 cigarettes a day for the last 20 years. Patient is on his current medications, and he takes his medications every day, including lisinopril 20 milligrams once daily, metformin 500 milligrams twice daily, Jardiance 25 milligrams once daily, and atorvastatin 20 milligrams once daily, and aspirin 81 milligrams once daily. On physical examination, patient is active, alert, and oriented times 3, in no acute distress or cardiac arrest. His respiration, circulation, and breathing airways all intact. His blood pressure at this time is 158 over 92. His pulse is 92 regular, and his respiratory rate is 18 per minute with effort, unlabored, temp 98.6, and OSAT 98% on room air. On further examination, chest is bilaterally clear with no adventitious sounds, and heart is no JBP. JBP is not raised. Hepatojugular reflux is absent. S1, S2 regular in rate and rhythm. There is no S3, no S4, no gallop. There is no peripheral edema, no swelling, tenderness, or signs of inflammation in his lower extremities. The other examination performed was the abdominal exam, which is abdomen is non-distended, bowel sounds positive, and normoactive in all 4 quadrants, and there is no mass, tenderness to report. The rest of the exam was unremarkable. Patient was asked that if he had any medications at this time and point, especially Cialis or Viagra in the last 24-48 hours, and he denied taking those medications. The diagnosis was focused on obtaining a 12-lead EKG. The 12-lead EKG showed ST depression with T wave inversions with no evolving Q waves, and patient at that time, because he had continuous chest pain that has not subsided, was given nitroglycerin sublingual 0.4 milligrams every 5 minutes for 15 minutes of 3 doses. The patient's chest pain did not subside, so I ended up activating the EMS by calling 911, and the EMS was dispatched within 10 minutes, and on arrival they repeated the EKG 12 lead, and it was the EKG showed evolving ST segment elevation with left bundle branch block, which was new onset. So code STEMI alert was activated by the EMS, and patient, the hospital was notified, which was a PCI facility, in the regional community health hospital, and the patient was transferred out quickly and safely to the regional hospital by ground. My provisional diagnosis on this patient initially was non-ST elevation myocardial infarction, but as the EKG changed and the condition of the patient changed, it was important and crucial to transport out the patient and transfer him to the emergency room for further evaluation. Thanks for watching.